Assalamu alaikum. Thank you very much, Mr. Chairman. I would like to say thank you very much to all the organizing committee for inviting me to this great prestigious meeting. Inshallah, النهارده we are going to run a debate about total knee versus patellofemoral arthroplasty. My role will be about total knee is the answer. So, how many of our patients present with isolated patellofemoral arthritis like that? How many of our patients present with mechanical malalignment like that? How many of our patients present without arthritic changes on the tibiofemoral in addition to other deformities? Okay, so the objectives, in the next few minutes, I'm going to discuss why are we debating, pros and cons of either procedures, and outcomes, costs, complications, and I'll finish with supporting evidence. So why are we debating? Well, isolated patellofemoral osteoarthritis, there is no gold standard for its management. Both patellofemoral arthroplasty and total knee are satisfactory and successful approaches. So I'd like to confess from the start that patellofemoral arthroplasty has several benefits, including sparing healthy knee compartments, less surgical trauma, blood loss, hospital stay, minimizing the risk of complications, easier recovery, bridging treatment for active younger patients. But the devil lies in the details. Well, let's discuss what about the indications. They are indicated in the isolated patellofemoral osteoarthritis with severe symptoms non-responsive to medical treatment. However, we have to have absent patellofemoral malalignment, or at least to be corrected intraoperatively, absent tibiofemoral disease, neutral tibiofemoral alignment, no gross obesity, obviously no evidence of inflammatory arthropathy. The contraindications, again, they are the reverse of what I've just mentioned, in addition to fixed flexion contracture more than 10 degrees in the knee, patella infra, in addition to CRPS and infection. Again, how many of our patients have these conditions? That's our typical patients in Cairo or in Egypt. In addition, total knee have some complications, but also patellofemoral arthroplasty have a lot of complications, including late tibiofemoral degeneration, which is basically the primary cause of failure, and high rates of reoperations, up to 63%, and revision up to 51% in some older series. So why total knee arthroplasty? Several studies showed that it's quite effective, reliable procedure even for the isolated patellofemoral disease with very low reoperation rate or revision rates. Can you see all these studies? If you concentrate in the column of the revision, it's mainly 0, with up to 3 cases in one of the series only. So to debate with the patellofemoral arthroplasty, we should have at least good outcome as the total knee, mainly the longevity and the revision and reoperation rate. However, and to be honest, total knee isn't desirable in patients who are young and active. And these are actually the real customers for the patellofemoral arthroplasty. And the high revision and reoperation rate might be attributed to the first generation patellofemoral arthroplasty. When it comes to the second generation and the new implants, this started to be less and less, and no significant difference between it compared to the total knee arthroplasty. However, after putting in the patellofemoral arthroplasty, we might have advancement of the tibiofemoral cartilage degradation. So if we suspect that this patient might have tibiofemoral involvement or might progress to that, we should not be or we should think twice before putting patellofemoral arthroplasty, and we would rather consider it as intermediate procedure. There is a caveat here, to be honest. It's worth mentioning that nowadays, because of the availability of the total knee and easier revision, this might indirectly increase the revision rates of the patellofemoral arthroplasty. So how we could make a decision? We need to involve the following factors, including etiology of arthritis, as well as morphology of the trochlea. And in my humble views, the real indication is whenever we have active young patient with trochlear dysplasia, along with or patellar fracture. these are the ideal candidates. The idiopathic patellofemoral arthritis might be more prone to progression rather than when it's compared to those with trochlear dysplasia or patellar fracture. And in one of the studies from Mayo Clinic, 59 patients had less progression of the tibiofemoral osteoarthritis compared to those without trochlear dysplasia. Other factors, obviously, if we have involvement of the tibiofemoral joints, I wouldn't proceed to patellofemoral. Obviously, the age of the patient below 60, active young, that's different scenario from those more than 60. Design of the patellofemoral implants available. Currently, we have good designs. And finally, the available evidence. So coming to the evidence now, what about the clinical outcomes comparing the total knee arthroplasty versus patellofemoral for, again, isolated patellofemoral arthritis? Again, you have seen this slide before, several studies, earlier studies even. Now we have more recent and more up-to-date implants on the side of the total knee arthroplasty as well, with decreasing, trying to decrease the revision rate. I came across this paper in 2019 from Journal of Arthroplasty about the clinical outcomes in patients younger than 55 years. So actually, these are the real candidates for patellofemoral arthroplasty. It was retrospective case matched cohort study, including quite a few scores with a minimum 2 years of post-operative follow-up. And it showed that actually the total knee performed better in the first year. However, at 2 years follow-up, they performed both equally well. So the take-home message out of that, it's indicated the patellofemoral, indicated in younger patients with isolated osteoarthritis who desire a more conservative approach. Any RCTs? Again, I came across this PAT randomized clinical trial. It's a very famous one in March 2020 in Bone and Joint Journal. It was single-center, double-blind randomized controlled trial, including 64 patients, including primary functional outcomes, including WOMAC score, functional section, as well as quite a few clinical and functional scores. The conclusion, no statistically significant difference between both in the WOMAC function at 12 months and also in the other secondary scores. Complication rates were comparable. No statistically significant difference in the follow-up up to 60 months. Now, you might argue that now it might be in favor of patellofemoral arthroplasty, but actually, I look at it from the different angle that total knee is great option, especially in our country where we don't have any patellofemoral arthroplasty prosthesis. Just to be honest, I came across this systematic review again. It showed that the patellofemoral arthroplasty might be superior to total knee, again, in the immediate or in the first 2 years post-operatively. Again, they reiterate its role in the active young population. But I came across this interesting study which showed that whenever you do total knee and you don't resurface the patella, actually, they showed that the worst preoperative osteoarthritis severity would actually predict superior knee-specific patient-reported outcomes, i.e., patients with more severe osteoarthritis have more optimized outcomes. This highlights that actually we might have just minimal contribution of the patella osteoarthritis to the knee function after total knee. This was quite reassuring to me. What about revision rates? This study in 2019 showed that, yes, patellofemoral might have shorter length of hospital stay, but they have 10-year survival of 92.3%, which was actually Avon prosthesis compared to 100% on the total knee arthroplasty side. Complication of the cost, as you'd expect, patellofemoral is less expensive alternative. However, it's associated with significantly higher 5-year revision rate. So to conclude, and I'm going to phrase now my personal perspective, due to the high revision rate, I would go for total knee arthroplasty definitely to be the best option for those more than 60 years. For younger active patients, especially those having trochlear dysplasia or patellar fracture, I might consider patellofemoral arthroplasty if it's available. Total knee, therefore, can be considered as an acceptable treatment still for these young population for isolated end-stage patellofemoral disease if we can't have this implant. and it would be considered actually the treatment of choice on those elderly patients. Thank you very much.